So yeah, let's get started. So today we're talking about assessing and addressing readiness to change. So as Mitch said, I am a clinical mental health counselor. I work for PARCA, and right now I'm a social service worker. So anytime they need a licensed mental health therapist or licensed mental health professional, I can jump into that role. Right now I am working on the Optimum study primarily, and I'm able to provide therapeutic support and case management services to pregnant moms with opioid use disorder. As Mitch said, I worked for what was basically a drug court program in Wyoming for 4 years, and I was trained in ASAM criteria, which we're talking about today. A big part of my job was writing evals and making treatment recommendations based on these criteria, and I have no disclosures. So the point of the presentation today, I'm trying to give you an introduction to how the criteria assess readiness to change, so that you can have some tools to understand where your clients or patients are at in their recovery. We want to create consistency on multidisciplinary teams, so we're all using the same language, setting appropriate goals for our clients based on where they are, and being able to make sense of assessments if part of your job is reading those. I'm not qualified to give a training for people to make assessments, suggest treatment levels, or anything like that. So it's not meant to be a comprehensive training, just an informal overview. So the American Society of Addiction Medicine came up with this comprehensive guideline for placement, transfer, and discharge of patients with substance use and co-occurring disorders. It's the most widely used criteria in the United States and is legally required in many states, so including Utah. So any state-funded treatment center has to use these criteria. And it's a multidimensional assessment. It has 6 dimensions. We're going to briefly go over those, though we're going to be focusing on readiness to change today. So the first dimension is acute intoxication and or withdrawal potential. So this is this client's current state. So are they in active use? Are they in withdrawal? Do they need a medically assisted detox, or are they able to succeed with a less restrictive treatment center with no medical component? The second dimension is biomedical conditions and complications. So this is their current physical state. Do they have illnesses that could complicate treatment? This would definitely include pregnancy, HIV, hepatitis C status or risk. Do they need round-the-clock nurse care, or can they thrive in a condition that doesn't have that? The third dimension is emotional, behavioral, cognitive conditions or complications. So this is anything that you're going to see a DSM-5 diagnosis for: psychological or psychiatric conditions, learning disabilities, things that are going to complicate treatment. So like I said, readiness to change is what we're talking about today. The fifth is relapse or continued use or continued problem potential. This is this client's current skill level. So if we're talking about can't do and won't do, readiness to change would be that can't do, and the fifth dimension would be readiness to change would be the won't do, and relapse continued use potential would be the can't do. So if you have all the motivation in the world, but you have poor impulse control, poor social skills, you are not likely to be successful on your own without treatment. And then the last dimension is the recovery or living environment. So what support does this person have? What is their financial situation? Who do they live with? Are they experiencing homelessness? Are they able to cope with their recovery environment? Or are they in a dangerous situation that they need to get out of? All of these things play into what kind of treatment level is going to be appropriate for them. So the idea here is that treatment is individualized based on a variety of biopsychosocial criteria that are unique to this person. And research has found that the least restrictive option is the best one. So what is readiness to change? So in readiness to change, we're exploring the client's readiness and interest in changing. This is the client's opportunity to speak for themselves. So it's nice because you don't need background information. You don't really need an ability to make a diagnosis. This is the client speaking for themselves and talking about how ready they are to change. What are they willing to do? What do they think they need to be successful? And when you're looking at this dimension, you should include readiness to change for other aspects of their life as well, their mental and physical health, their employment, et cetera, because all of these things are going to dictate how successful they are in treatment. And we're assessing the risk of readiness to change based on the stages of change. So the stages of change, which is also known as the trans-theoretical model, is an overarching framework that is supposed to guide motivational strategies in addiction treatment. So the idea is that it's acknowledging that motivation is multidimensional and it's fluid, and so clients are not stuck in a static state where they can't change their motivation level. So it's nice because I think it can be really frustrating as a clinician or a therapist or social worker to feel like, well, this client isn't motivated, so what can I do? And this framework just gives us the idea that just because they're feeling unmotivated today doesn't mean there's not some things that we can do to help them move through this stage of change and get to a place where they're feeling a bit more motivated. So just quickly, theoretically, we start in pre-contemplation, move to contemplation, preparation, action, maintenance. For maintenance, a client can continue in their recovery and move out of the cycle, or oftentimes can experience a recurrence or relapse. And it shows them going back into pre-contemplation from there, but really they could re-enter the cycle at any point. And it's just important to note that it's an upward spiral. So it's not starting again at square one. When somebody experiences a recurrence, they're able to have a strength in their use and learn from that, and it's an upward spiral. So let's define each stage quickly. So in pre-contemplation, the client is not considering change. They're aware of a few negative consequences. However, they're unlikely to take action soon, which we can define as about the next 6 months. So they might be feeling like this pup here with their head under a blanket, no motivation to change things up. The primary task of the clinician or the therapist or social worker at this point is raising their awareness. And then we're going to talk about needs at each stage, and I'm talking about needs for moving through their stages, not their needs in general. They might have a lot of needs. So they need information about linking their current self-identified problems with their use. They're going to need education about the consequences of their use. For example, if they identify that they are experiencing symptoms of depression, they may need education about how drinking alcohol can exacerbate those symptoms. They're going to need some ambivalence. So in pre-contemplation, they're really not considering change, and we want to get them to a place in the cycle where they feel unsure, they feel ambivalent, so they can move forward from there. And then lastly, they need support. And of course, our clients need support at every stage, but especially in the stage where they may be feeling a lot of resistance, maybe they've had negative experiences with prior treatment, just knowing that somebody is in their corner and not trying to tell them what to do, I think is really important at this stage. So the next stage is contemplation. So this is when the client is aware of some pros and cons of substance misuse, but feels ambivalent about change. So they've not yet committed to change, but might be thinking about starting healthy behavior in the next 6 months. So like this pup, they may be feeling some negative consequences of their negative behavior or their maladaptive behavior, but they're not really quite there where they're ready to take the next steps. So their primary task of the therapist is to helping this client resolve ambivalence and helping them to choose change. They need to explore conflicts between their personal values and use and explore their feelings of ambivalence. And they need some awareness of consequences and benefits. All right, so the next stage is preparation. This client has decided to change and begins to plan steps towards recovery. They believe that they're changing their behavior can lead to a healthy life and are ready to take action within the next 30 days. But they're not quite sure what to do, and they're still considering what they need to do in order to change. So they need help with identifying appropriate change strategies, and they need some strengthening of their commitment and education about what options are available, treatment options or other kinds of support options. The next stage is action, ready to take the leap. So the client is taking the first active steps towards change. They've made changes in the past 6 months. They're trying new behaviors, but they're not yet stable in these changes. The primary task here is to help them implement change strategies and learn how to prevent relapse. So their needs are implementing change strategies and education on relapse. In the maintenance stage, this client is establishing new behaviors on a long-term basis, and they have a lot more stability in their changes. So this is my late great best friend here on a paddleboard. And just the idea is that you have more support in place, more stability. You're still having to work, but it's not working quite as hard because you've put some things in place to make these changes more natural and intuitive and more stable. So the primary task here is you're continuing to develop new skills for recovery, and you're helping them with that. And their needs are they need help with relapse prevention. They need reassurance. They need evaluation of what they're currently doing to change. And they need some help redefining their long-term plans. And then lastly, we have recurrence or relapse, which isn't a part of everybody's recovery, but is definitely a normal part of recovery. And this is when a client has experienced a recurrence of use, a recurrence of behavior, a recurrence of symptoms. I guess this dog likes to chew up toilet paper. And so the primary task here for a support person is to help them cope with any consequences of their use and to decide what's next, what are the next steps. So they need help re-entering the change cycle. They need help making sense of their use and what happened, and they need some support and engagement. This is such a vulnerable time. It's really easy to get frustrated with a setback and to just give up. And so being willing to give some more support in that time is important. So how do we assess readiness to change? So we want to ask the right questions to assess the client's thoughts. And these conversations are hard to have and people can often feel defensive. So we just want to remember to use motivational interviewing skills, basic therapeutic skills, and just compassion and empathy, using non-judgmental body language, tone, eye contact, reflecting and validating what they're saying, and really listening to their answers. And sometimes we want to read between the lines. Obviously, we don't want to put our own opinion into this process too much, but sometimes clients are saying something without really saying something as well, if they're not comfortable being outright. So here are some questions that you could ask. Do you want to cut down on your use? Are there any drawbacks to your use that you see? And that question might help you assess if they're in pre-contemplation or contemplation. Look for any wavering, pros and cons. Have you tried to cut down in the past? You could look for action statements such as, I'm trying to cut down. You could ask them if they are abstinent, and if they are, how long they've been abstinent and what strategies have helped them with that, help them be successful. You could use some scaling questions. For example, you could ask, how confident are you that you can change? How important to you is it that you change your behavior? And then ask, what would it take to get you from X to Y? Or why isn't that number lower than X? You could ask them to recall a typical day and ask them to focus on what their use looks like in that day. Ask them, what are their thoughts about being here? What are their long-term plans for use? What do they think they need to be successful? And this could be anything from what kind of treatment to what kind of 12-step programs, what kind of activities, and what are they willing to do at this time? And if anybody is interested in a more formal assessment tools, there's some listed here. And I just want to point out that these stages, even though they look really simple in that diagram, they're not cut and dry. A client can move back and forth between the stages from session to session or cycle quickly through them. And so it's important to just always be listening and paying attention and assessing their readiness to change so that you can have appropriate interventions and appropriate conversations. All right, so let's do a quick quiz. So if you're tuned in right now, you could use the chat box if you want, or just think about your answer. So I'm gonna read through this little dialogue. So if someone were to ask, what brings you in today? Sorry. Well, really, my wife told me I had to come in. She says she's gonna leave me if I don't stop drinking. Personally, I don't think it is really a problem. I mean, I guess I can see why she gets angry when the kids are around, and I know it was really bad that I went to work kind of still drunk the other day, especially since my boss could tell. Sure, in a perfect world, I could just snap my fingers and not do it anymore, but I don't think I can do that, so why even try? I don't know, maybe after the holidays I can think about cutting down, but right now all my friends are in town. So if you wanted to take a second to just see if you could figure out what stage this person was in. All right. So contemplation is what I would say, because they see some pros and cons. They might be considering change, but they're just not ready quite yet. Do another one. So how are things going? Well, Christmas is coming up. It's just so crazy. When I think about last Christmas, I was just getting out of jail. I didn't buy my daughter one present. My mind was in such a different place. This year I got to spend it with her, and we were going to do the real thing. I have a meeting I'm going to go to the night before, and it's like a family thing, so I'm going to bring her. And I just got that promotion, so I'm not worried about presents at all. It just feels so good. Oh, and did I tell you I started going to church? So just take a second. Oh, Jerry thought pre-contemplation for the last one. I guess we'll have to agree to disagree about that. Anybody have any guesses about this one?
I can get, never mind.
What were you going to say, Mitch?
I was going to say maintenance, so I'm correct. I'm right.
Yay! I can't really, it's hard for me to see the chat. Yeah, Jerry, you got it right. All right. So lastly, so we've been talking a lot about your use. What are your thoughts on that today? Honestly, I know something has to change. I thought I could just write it out, but something always comes up and I end up just using. I know DCFS is going to take my baby if I don't do something soon. But honestly, it really freaks me out. What are my other kids supposed to do if I go to treatment? I feel like I don't even know how it all works. I'm ready to do something. I want things to be different, but I don't know what. Any ideas? I don't know, Jerry, you want to chime in on why you think contemplation?
It just sounds like the person is thinking about it quite a bit.
Right.
Hasn't really done anything, you know, like to kind of engage in treatment. So I can't imagine action would be it.
Right.
Maybe I'm wrong. Maybe this is action. Is that what it is?
Any other thoughts? Any other thoughts?
I was thinking maybe preparation.
I think Mitch is learning about this right now in school, so he's on top of it. I would say preparation personally, because they want to change. They need some information about what their options are, but they're ready to start thinking about those steps. All right, what happened? Okay, so how can I help? So let's talk about some practical ways that you could help your clients if you've identified that they're in one of these stages of change. So for pre-contemplation, this stage, it's super important to be establishing rapport and building trust. Some ways that you could do that is asking permission to explore these tough topics that they're trying to work on, or that you have heard that they need to work on. You want to use motivational interviewing strategies like open-ended questions, being clear about your role in the rules of whatever kind of relationship you have. So whether that's talking about confidentiality or the client's responsibilities, clarifying that you're not there to impose goals on them, and emphasizing their own personal control in making decisions. And then kind of as always, we want to be culturally sensitive, because that helps that person know that this is a safe place and where you're trying to understand them as an individual. You want to commend them on taking steps to get to the appointment, and you can tie in their motivation. You must really care about this pregnancy to be here today. Giving some education and assessing what they already know and filling in the gaps. So one way to do that might be to talk about previous treatment experience. And education can be tough because people can get really defensive, and you want to be sensitive with that, and maybe like thinking about how much rapport you have with that person before you get into those things. When you present it, you might say, you know, this is what experts have found, or this is what research has found, as opposed to thinking, well, I think, or giving your opinion. And depersonalizing can sometimes make the client feel more comfortable. So saying things like, when people use opioids when pregnant, instead of when you. But on the other hand, you want to personalize the information that you're giving, instead of just giving them this plethora of information about use, tailoring it to their goals and their conditions. And then giving them a time to reflect. So how is this all sitting with you? What are you feeling about all of this? And we also want to be careful not to give all of our education on the negative aspects of using, and also give education about the hopeful facts that people have been really successful using medicated assisted treatment, and give them facts about that as well. We want to explore pros and cons. You could phrase this as, what are the good things about using and what are the less good things? And then we also want to validate in this stage their reasons for using. They are using for a reason. We want to explore, we want to ask them why they think another person or agency thinks they have an issue. If they come in and I don't have a problem, I don't know why I'm here, this might be a good way to get the conversation started. Okay, well, if your partner asked you to come here today, or if DCFS asked you to come here today, what do you think they would say? You want to help that client explore their self-identified goals and how will using help or hinder these goals, and then exploring barriers to change. In the next stage, in contemplation, you want to normalize ambivalence and highlight that other people have been able to move past that feeling by talking it through and sticking with treatment and sticking with whatever relationship you have with them. You want to explore intrinsic versus extrinsic motivation. And we want to get the intrinsic motivation up. And so one way to do that would just to be putting a lot of emphasis on that when they bring up intrinsic motivators, and summarizing them and doing reflective listening to really highlight those things. We could also try turning extrinsic motivation into, that sounds negative, into a positive if they're upset that their spouse wants to come in, making statements such as, I'm just struck by how much support you have from your spouse, that they really do want to see you improve. Examining personal values is a good thing to do in the contemplation stage. We want to talk about how they relate to this person's use. And then, especially if we have that rapport, pointing out the discrepancies between their personal values and their behavior. We want to discuss clients' expectations of treatment and educate them on the reality. We want to ask about positive and negative experiences with abstinence in the past, and build a relationship and show interest in other areas of their life. So it doesn't have to always be about their use. We want to show curiosity in their unrelated goals, and often we can tie in how using plays into that as well. More concrete intervention you could do is a decisional balance sheet. I have an example of that. So it's really just a more in-depth pros and cons. So you can see it's the benefits of changing versus the benefits of not changing, the costs of changing versus the costs of not changing. So it just really helps that client get clear on why they're using, why they might be thinking about changing, and weigh it out. All right, in the preparation stage of change, this person often has less resistance. They're more open to hearing about things. And this is a really good time to offer them a menu of options. What are all of the different treatment levels? What are the things that they can do? You might suggest an assessment at this stage, depending on your role. A place like ARS here in Salt Lake City that does assessments, or another similar facility. If you do have the expertise to suggest a treatment level, this is a time that you could offer that if they're open to that. Can explore and lower barriers to change. So this would be like negotiating finances, childcare, employment, transportation, other potential barriers. And we want to balance here that these are real things. These are real complications and real reasons that people don't engage in treatment. And at the same time, having the conversations with our client that, sobriety is the cornerstone of all of these parts of their lives. And without that stability, it's hard to be successful in other areas. You want to enlist social support and just evaluate who really is supportive in their lives. And when you figure that out, encouraging clients to announce their plans to change to these people. Explore treatment expectations and the client's role. So what are you hoping to get out of treatment? And what do you have to put in to get for those things to happen? You could do a change plan worksheet, which here is an example of that. You can get them off the internet. So as you can see, it's just going through the changes they want to make, the reasons, the steps, the ways other people can help, ways that they'll know the plan is working, some things that could interfere with that plan, and what they can alter if the plan isn't working. And it just can be nice to have something for the client to take home and refer back to when they get confused about where they're headed. In the action stage, we're wanting to support a realistic view of change. So this is a stage where people often feel that pink cloud, as we say in the addiction world. So it can be really easy for a client to just get really motivated and feel awesome and see a lot of benefits and just want to make all the changes really quickly and talk about school and work and I'm going to get my kids back and all of this stuff all at once. And so we want to try to slow them down just a little while still celebrating those goals, but encouraging them to take small steps. We also want to prepare them for some of the negative feelings they might feel in recovery. So we talk about hitting a wall where when you don't see those changes coming as fast as you wanted or expected, just getting really discouraged and not really wanting to engage anymore. And if you can normalize those feelings and normalize any setbacks, it might help them push past those things a little bit easier. You can make a functional analysis, which is basically a relapse prevention plan where you talk about triggers and high-risk situations, people, places, and things, why those things are triggers, and develop coping skills that are appropriate for each trigger. This can help this person find new reinforcers of positive change. So this could be things like volunteer work, 12-step meetings, goals with work, goals with education or health, more social time, spiritual and cultural activities, learning new skills and hobbies. All of these things can be reinforcers. Can assess social and family support at this stage. Continue engaging and reinforce the importance of remaining in recovery. If someone is having a lot of successes in their action stage, it can be easy for them to say, I've got it, I'm good. I don't need to go to therapy anymore. I don't need to be on medicated assisted treatment anymore, whatever it is. And just reminding them that this is still a vulnerable stage and we need to keep doing what's working. Normalize increased emotions, mental health symptoms, and support through treatment. It can be a common experience for someone to have a flood of emotions and symptoms right after achieving sobriety. And this could be because they've been using to cover up these emotions. It could also be some neurological changes that are going on in recovery. And just to give them information about, yes, this is normal, and to help them find a therapist or a psychiatrist or whatever it is they need to feel supported through that time. And then the last one I listed is role play, and role play can be a bit goofy. I found that in a group setting where I have good rapport with the clients and they have good rapport with each other, it can be kind of a fun thing to do if you make it that way. And other clients can debrief and identify strengths and weaknesses. Otherwise, if it feels too goofy, you could also do it informally with a client, saying things like, what are some things you could say if you ran into Robert, or something similar to that, so it doesn't feel quite like you're putting them in the actor's chair. All right. And in the maintenance stage, we want to affirm clients' resolve and self-reliance, celebrate with them their successes. We want to maintain contact and availability. Again, this is a time when people can drop off, and just reminding them that this is working, let's keep going. We want to reevaluate long-term goals. This is a time when they've probably accomplished some short-term goals and where they might be a little bit more receptive to thinking about the long-term, so taking advantage of that. We want to develop a fire escape plan, which is basically a plan for slips in thinking or actual uses, because we want to keep those slips or lapses from becoming full-blown relapses. So helping the client to recognize common thinking patterns. I took one drink, so I might as well keep going, and helping them come up with a plan for disputing and challenging those thoughts. I can stop, I can repair this now. Who can you call in these situations? Can you review your relapse prevention plan? Can you schedule an appointment as soon as possible? Those kinds of things. And then the last one is one I use commonly. It's developing mooring lines and reviewing them regularly to watch for relapse drift. So here's an example. I usually do it on a note card. Have a client come up with 10 healthy behaviors to do weekly. And these should be quantifiable things, measurable, and things that they can actually control. So it shouldn't be, don't get angry with my kids, or don't get cravings, because they can't control those things. coming up with things that are easy to review once a week, either by themselves or with somebody, and say, have I done these things? And we say if you've missed more than 2, you may be headed towards a relapse and need to take some time to evaluate that. And then on the back of the note card or on the bottom, 5 things to avoid. And really, if any of these things are coming up that you're trying to avoid, that would be something to pay attention to. And lastly, recurrence or relapse. In this stage, we want to help the client re-enter the change cycle. An important part of this is just thanking and congratulating them for even returning to treatment or wherever they are that they're meeting you. And being willing to consider moving forward is a huge deal. We want to normalize that this does happen, and it's not unique to them. It's a common part of recovery. And we want to help them decatastrophize things. So get out of the mindset of I'm starting over from square one, and help them see that they can move forward in a strong way. We want to help them explore the meaning of their use and reemphasize that relapse isn't usually a spontaneous incident, and it usually can be. If we can go back, we can see, oh yeah, there were signs a week ago, a month ago, and helping explore those events and those emotions that led up to the use. We want to go over those coping strategies and reevaluate what works and what doesn't work, and it's really important to maintain contact in this stage. Boundaries are always important, but maybe having a little bit more flexibility and more availability for that client, because they're going to need a lot of support. All right, so most of the information from this came from my own experiences and these 2 sources. So the ASAM book, which is great, the criteria book, and then a treatment improvement protocol from SAMHSA called Enhancing Motivation for Change in Substance Use Treatment. So if you're interested in a more in-depth look, those would be where I would point you. And that's all I have for you today. So if anybody has any questions, I would be happy to hear them. You could use the chat box or just say them out.
Hey, Ashley, it's Gina. I have a question.
Yeah, of course.
So you talked about developing hobbies to help.
Yeah.
What kind of hobbies do you recommend?
Yeah, I mean, like it could be a ton of things. And I think it's something that's really hard for people in recovery, depending, not everybody, but a lot of people, their whole lives have been using culture. And so I have found that clients have a really hard time. And a lot of times, people are struggling with low self-esteem. So trying something new can be challenging, but it could be anything. It could be journaling, doing crafts, joining some sort of group, a book club like we're starting, or exercising is obviously great for many reasons. So getting into a gym, I find that's one of the easier ones to suggest. And if anybody else has ideas about what's helped them or their clients, definitely share those out. But I think taking anything that you hear, like an interest that you hear them talking about, and just trying to foster that. Trying to give, I heard you talking about that you used to do pottery in high school. There's this pottery class that's free that you can try out, things like that. Does that answer your question?
Yeah, thanks. I think it's interesting, but like you said, it is hard to try something new as an adult sometimes, especially in this population. So I was just curious about that. Thank you.
Yeah. Mm-hmm. I think it depends on your role too. I think there are some roles where it'd be appropriate to go to a class with somebody, or if you are seeing clients in a group setting, linking people up, which can have positives and negatives. But if you feel like there's 2 people that would be appropriate to link up to go do something together, be more comfortable.
Ashley, this is Mindy. Can you go back to the book slide?
Of course.
Ashley,
Thanks. I just wanted to get a picture.
Yeah, no problem.
Ashley, my question was, how can we, I wonder if you have advice for like the treatment team rather than the client, the treatment team, because I've heard like a lot of treatment team members can get really negative, maybe, like, oh, this is so-and-so's third relapse, this is getting ridiculous, or I don't know what to do anymore, or we almost see that happening, and that can cause a lot of dissonance even in the care that's being provided. How would you either go about motivating yourself or your colleagues to maybe change the way they're looking at that situation or the way they're thinking about it?
Yeah, I mean, I think just like with anything, I think group supervision of your own, whatever that means in your field, is just really important, because it can get really frustrating. We get to see people that have substance use disorders. We get to see them at their best, and then we get to also see them make choices to go out and use. And it can be really hard to keep that perspective of this is part of the process, and and to not get into that catastrophe mode ourselves. And so I think just like with any of these roles, we need to take care of ourselves. We need to have self-care. We need to think about those things on our own time and flush out those frustrations with our coworkers and our supervisors as much as possible. And then just reminding yourself, if it means going back and reading some of this stuff again, okay. And just reiterating to yourself that, these are the things that have been proven and research has shown that this is part of the process and that this will help. And just going back to those basic motivational interviewing skills, because that kind of removes your own opinion and your own investment and puts it back on the client of this is about them and not about me. Does that help at all?
Yeah, it does. I love that, because I think a lot of work here at Parka is about taking down stigma, right? And I feel like
Totally.
That's kind of the first place, how can you change stigma within yourself and those closest to you? And that can have big changes. So thank you.
Yeah, and we talk about it a lot, but I really think taking care of yourself is your obligation. And self-care should definitely, it gets hard. And I get that. I have a 2-year-old and a busy life, and it can be hard to take care of yourself, but you have to see it as part of your job, whatever role you're in, if you're working directly with clients or patients. All right. Any other questions? Okay, well, feel free to reach out to me via email. I guess I don't know how to get that information to people, but if anybody had any further questions or just wanted to talk things out, my email is definitely open.
Yeah, do you want to put it in the chat box, and I can
Sure.
put Parka's too?
Yeah.
Okay, if there's no other questions, we'll go ahead and end it. I won't close the meeting yet in case anyone wants to go into that chat box and get the email or anything, but thanks for joining us. And Ashley, thank you so much. That was a great presentation. I know I learned a lot, and I hope everyone else did too.
Thank you everybody for joining. I really appreciate it. And I'll be doing a presentation next month on to be determined topic.
Oh yeah, thanks for mentioning that. Ashley, you were gonna do a part 1 and a part 2.
Right.
You were able to do a lot in this presentation, so
Right.
You'll do something different next month, which we're really excited about.
Yes.
So thank you. Does anyone have anything, final words or anything?
Good job. Thank you.
Thank you.
All right, and I'm gonna give you a clap on the reactions.
Yeah, that was great, Ashley.
Thanks, Ashley.
Thank you.
Thanks, guys.
All right, have a good day.